All right.
So it's a great honor to share the stage with the giants who talked before me and who are going to come after me. Thank you very much for the invitation and the opportunity to share our work. I'm a pediatric anesthesiologist, so I will share my own research with the genetics in children who receive opioids during surgery. So I don't have any conflicts. So the objectives, initially we'll talk about opioid-related malpractice claims. So many children and even adults die from opioid-related respiratory depression at home setting, the hospital setting, and also abuse setting. So we'll briefly talk about perioperative opioid-related deaths and malpractice claims, then how we changed our practice and reduced incidence of respiratory depression in the hospital last 10 years. Then we will talk about genetic variations related to opioids, then how the race and other non-genetic factors influence outcomes, perioperative outcomes. Finally, we'll see how we have used some of the genetic research we have already done into our clinical practice already. So we know, at least in children, we see inadequate pain relief because of the fear of respiratory depression. Clinicians use less opioids. We see a lot of inadequate pain relief. And also we see significant side effects, including nausea, vomiting, and respiratory depression. It affects 1 in 2 children. It's mainly because of 2 reasons. One is a very narrow therapeutic index of opioids, and also a huge inter-patient variability we see very frequently. Because of these, we cannot predict who will have problem, who will have more pain. So patients stay in the hospital longer because of inadequate pain relief or some side effect. That accounts to economic burden and poor satisfaction. We all know about opioid side effects, and the most common one is itching, and nausea, vomiting is next. And the one thing we worry about is respiratory depression, apnea, and death in children especially. The next one, especially in adolescents and adults, opioid dependence and addiction is a major problem. So I'll briefly share our experience of medico-legal implications related to perioperative opioids. Tonsillectomy is the most common surgery in children, I think next to ear tubes. And so tonsillectomy is more painful, so we chose that population for collecting data. So we collected 26-year worth of data from National Malpractice Claim Database. It's called LexisNexis, which is very close to Cincinnati. And in that, we found 242 malpractice claims related to tonsillectomy, about 100 deaths and 140 injuries, about 40% deaths and 60% injuries. The injuries are surgical injuries from the tonsillectomy surgery, soft palate, and other injuries, but anesthesia-related injuries were anoxic brain death and brain injuries mainly. So what we found is, unlike other surgeries, tonsillectomy surgery, even though it's very common, it's associated with very, very high risk for malpractice claims. And bleeding, surgical bleeding, post-tonsillectomy bleeding was the most common cause for malpractice claim. Importantly, for specific to opioids, we saw that almost 16% of death claims and 4% of injury claims were related to opioids. And I will go in detail what kind of opioids were used. And opioids were associated with the highest monetary awards. So almost death claims were associated with $1.6 million in 2013 dollars, and injury claims more than $3 million. These are anoxic brain injuries. Patients live longer. For maintenance, the awards were more. So what we learned, the most commonly associated opioids with malpractice claims are codeine and morphine, fentanyl, and meperidine. And the common risk factors we identified during our malpractice review are ultra-rapid metabolizing status of CYP2D6 enzyme, which is a microenzyme in the liver. And if a patient is an ultra-rapid metabolizer, that patient will form almost 10 times higher concentrations of morphine for a given dose of codeine and can get into trouble. And obesity and sleep apnea are associated, and prescription errors, mainly with morphine. I think in 2 deaths, the pharmacist dispensed 10 times higher dose of morphine. Instead of giving 1 milligram per ml solution, they dispensed 10 milligram per ml solution that contributed to 10 times higher dose. And inadequate monitoring and premature discharge are commonly associated. So this is our hospital's experience from 2006 all the way to 2014. I don't even show the 2013-14 data because we have not had anybody receiving naloxone in the last 2 years. So we did multiple steps to decrease incidences of naloxone requirement for respiratory depression related to opioids. This is for all children in the hospital, not only surgical patients and non-surgical patients receiving opioids. And in 2006, you can see that this is interval between number of days in between naloxone use. So you can see that we had almost every month we had a patient who was receiving naloxone. And we did multiple interventions, and the most important interventions that helped us were like 4. One was use of sedation score every 4 hours in patients receiving opioids. We use Ramsay sedation scale. That helped us a lot. Then also in the evening shift, after hours, after 5 p.m., there's nobody in the hospital looking after all patients receiving opioids. We added another person. That helped a lot. Then use of ultrasound-guided regional nerve blocks in children, that improved, and use of IV acetaminophen. These are the 4 major factors that contributed to significant drop. And as I mentioned, so in the last 2 years, we have not had anybody who had naloxone for respiratory depression in our hospital. And those are significant events, but we still have patients who are getting into subclinical respiratory depression. They're on the verge of getting into problem. So this research was stimulated because of those variations. So to summarize what we learned from our naloxone data, we had like 100 children who received naloxone between 2006 and 12. And almost 70% were postoperative patients. Most of the incidences happened on the day of surgery or within the first 24 hours after surgery. And many patients went to ICU. ICU patients get a lot of morphine, fentanyl infusions. They are extubated prematurely, and they get reintubated for respiratory depression. The risk factors we identified were sleep apnea, children less than 1 year of age, small for age, less than, say, 5th percentile for weight, prematurity, developmental delay, and use of oxygen sometimes mask respiratory depression, underlying respiratory depression, that is a risk factor, and use of concomitant sedatives, especially benzodiazepines, and premature extubations. So that led to how we can identify proactively patients at risk. So that led to a personalized pain management with opioids. So at least in my mind, it has 2 simple steps. One, we had to identify who's at risk. Then we can tailor our therapy or change our management or reduce the dose, increase the dose, or use different opioid based on the underlying risk. So most of my talk will focus on the identifying the high-risk patients. We have just scratched the surface, so we have a lot more research to do in the next 10 years or so to target interventions based on multiple genes. We all know about CYP2D6 and codeine-related deaths, so I will spend less time on that. There are multiple deaths related to codeine in breastfed infants whose mothers were taking codeine for C-section pain, related pain, and also tonsillectomy patients. There are multiple deaths. That's why the FDA recently warned against the use of codeine. There's a black box warning on codeine for 2 purposes. One is breastfeeding moms, and the other one is for tonsillectomy of surgery in children. So, and ultra-rapid metabolizers have a problem with codeine. Briefly, codeine is metabolized by CYP2D6 in the liver, and it forms morphine. So codeine as such doesn't have any analgesic property. It's a prodrug. Morphine is the analgesic metabolite that results in analgesia and also side effects. If you take the whole population, we can put them into 4 different buckets. So most of us are either intermediate metabolizer or extensive metabolizer. In the US, especially in Cincinnati area, we see about 10% are poor metabolizers. For metabolizers, they do not have adequate CYP2D6 enzyme, so they do not convert codeine into morphine. So they don't get any benefit from codeine at all. So those patients have inadequate pain relief for metabolizers. On the other extreme, in Caucasian, predominantly Caucasian population, so about 2 to 3% are ultra-rapid metabolizers, and they will have more side effects for a given dose of codeine. So on the other hand, if you go to Ethiopia, the calculation changes. In Ethiopia, almost 30% are ultra-rapid metabolizers. So it is not recommended to give codeine kind of drugs, opioids, including tramadol, hydrocodone to people from Ethiopian origin. So the drugs that are metabolized by CYP2D6 are not only codeine, so the tramadol is equally affected, and hydrocodone to some extent, and oxycodone is also affected. So oxycodone is affected the least, but it goes through CYP2D6 pathway in addition to CYP3A4 pathway. Opioids, oral opioids that are not affected by CYP2D6 are typically morphine, and oral hydromorphone. So this is the hydrocodone pathway. You can see that CYP3A4 contributes to 50% of metabolism, and CYP2D6 contributes to another 50%. And the CYP2D6 metabolite of hydrocodone is hydromorphone, which is 4 or 5 times stronger than morphine. And oxycodone, we know that the predominantly is by CYP3A4, and about 3 to 5% is by CYP2D6. And that forms oxymorphone. Oxymorphone is almost 14 times stronger than oxycodone itself. So we talked a lot about transporters this morning. The major difference between oxycodone and codeine are oxycodone as such is a prodrug. So 85% of the analgesic efficacy comes from oxycodone. Only 15% of the analgesic efficacy of oxycodone comes from oxymorphone, which is the CYP2D6 metabolite. And compared to codeine and morphine, oxycodone has better bioavailability. Another major difference between oxycodone and the rest of the opioids we currently use is that the oxycodone's concentration is higher in the brain than the blood. For morphine, fentanyl, methadone, all other drugs, if you look at the blood and plasma concentration, brain concentrations, the plasma concentration would be higher, and except for oxycodone. And so this is our study. From what we see is that tonsillectomies, we focus on tonsillectomy because that's the most common study, population, surgical population in children. And so we focus on that population for our study. And tonsillectomy is done for 2 major reasons. One, for sleep apnea, and which is a growing problem because of childhood obesity. And the other problem is recurrent tonsillitis and adenoiditis. So if you overlap the CYP2D6 metabolizing status and sleep apnea, coexisting sleep apnea, even the extensive metabolizers are at risk for respiratory depression, and that's what we see. And the FDA recently warned against the use of codeine, and they did not say do the genetic test. They said a blanket statement because this is very unique for tonsillectomy. Most of the patients, almost 70%, have sleep apnea. They said that the sleep apnea patients are at risk for any opioid-related respiratory depression. We should be very careful in giving any opioid, including codeine. So that's why we looked at specifically whether the extensive metabolizer status plus addition of sleep apnea layer increases the risk of respiratory depression even with the lower metabolism. So that's what we found. So in that, our study, we have 400 children who had the tonsillectomy, and we looked at everyone's genotype, their PK with the morphine, and also the clinical outcomes. And this is, we followed patients for 3 days after surgery for mainly post-operative pain management at home setting, whether they have good pain control with codeine or oxycodone now, and also whether they had any side effects. So if you focus on the slide, the graph on the right side, you can see that we divided the groups into low CYP2D6 activity and high CYP2D6 activity. You can see that the y-axis is the adverse effects, incidence of adverse effects. You can clearly see that the CYP2D6, higher the activity, higher the risk for adverse effects. what else we found? So we also found that the day of surgery, immediately after tonsillectomy, the evening after surgery, even if the child doesn't receive any additional codeine or morphine or oxycodone, and they get into more problem. That points to the fact that whatever we give in the OR along with the anesthetic, they may have lasting effect beyond anesthesia. And that's what we found. So the evening after surgery was the highest risk for respiratory depression and sedation. And we just briefly talked about CYP2D6 activity, higher the activity, higher the score, sedation. And for each patient who has higher degrees of pain before codeine, and they tend to have better effect with codeine. And girls, compared to boys, have higher incidences of sedation with codeine. We see the same similar sex differences between boys and girls with morphine as well in the hospital. So the FDA came up with warning in February 2013, saying that not to use codeine for tonsillectomy patients, for children undergoing tonsillectomy. And they said prescribe alternative analgesics, but they did not recommend anything specifically. And if one has to use codeine, they had to justify the benefit of using codeine. So in our hospital, we changed our practice even before the FDA's warning. This is our standard post-tonsillectomy home management of pain. So under 6 years of age, we do not use any opioids for children who undergo tonsillectomy. And so the reason for age cutoff 6 is that most of the deaths associated with the codeine and opioids in the past were in children 5 years and younger. And to our surprise, we thought we are not going to give codeine or any opioid. We will see more inadequate pain control, more phone calls and ER visits. To our surprise, we did not. And use of routine scheduled use of oral acetaminophen along with dexamethasone. Dexamethasone we give intraoperatively for prophylaxis, for PONV prophylaxis. That helps to reduce swelling and also reduce pain and improve appetite. Then we use dexamethasone every day for 3 days for all tonsillectomy patients. For children more than 6 years of age, we follow the same routine, oral acetaminophen on the day of surgery and up to 3-4 days. And we add ibuprofen from post-op day 1. And our surgeons initially worried about post-tonsillectomy bleeding, and we follow our cases for 3-4 days, and not only 3-4 days, for 7 days for bleeding, we have not had any increase in bleeding with ibuprofen. Then only difference is we add oxycodone every 4 hours, the lowest possible dose, which is 0.1 milligram per kg, and only as needed basis. So this is the CIPIC guideline, which came early this year, and they say for ultra-rapid metabolizers, do not use codeine, and do not use tramadol, and to some extent avoid hydrocodone and oxycodone because of potential for excessive side effects in ultra-rapid metabolizers. And poor metabolizers, the same recommendation, don't use codeine and tramadol, and hydrocodone if you can avoid, and oxycodone if you can avoid. Oxycodone is relatively safer. As I mentioned, 85% of analgesic activity of oxycodone comes from parent drug, so it's still good. And so this brings to the genetic variations related to opioids. So we can see this slide is complex, and we have genetic factors contributing to it and non-genetic factors contributing to it. And I'll take time to explain this slide a little bit more. We know about non-genetic factors. We know extremely young children, premature children, and extremely old patients, geriatric patients, are sensitive to opioids and they get respiratory depression. And we also know women have more PONV with opioids, and we didn't know much about respiratory depression risk between girls and boys, children, and we find that codeine causes more sedation in girls and same doses, and morphine, same higher dose, will cause more side effects, including nausea, vomiting, and respiratory depression in girls than boys. And the weight, obviously, higher the weight, higher the dose of opioid we give, and also that can the dose-related response we see, and additional use of benzodiazepines and the sleep apnea can contribute to risk. And patients with high stress and anxiety, they have higher pain and they need more pain medications as well. Focusing on the genetic aspect, I have 4 different boxes here. Yeah, this is the metabolizing enzyme. We briefly talked about CYP2D6 for codeine. So for morphine, CYP2D6 doesn't play any role. For morphine, it's UGT2B7, which is uridine gluconyl transferase in the liver. And Dr. Ivan Krush have a nice lecture this morning about transporters, including the ABCB1 transporter, which is the blood-brain barrier transporter, and OCT1, which is in the liver, and ABCC3. So then we see the pharmacodynamic differences because of opioid receptor-related changes and signal transduction-related changes. In that, we see a few genes. So I have listed the genes here. And so the ABCB1, besides the transport, it also affects amount of morphine within the brain, and that's available to opioid receptors. And also we will talk about fatty acid amide hydrolase, which is in the endocannabinoid pathway, and mu1 receptor gene, and COMT. Everyone knows about COMT, so we will talk about that as well. So whenever we have pain, so for example, surgery or hand pain, we touch something, so the pain signals go through the spinal cord to the brain. And so people perceive the same pain differently. That's because of, say, how we perceive pain is determined by the amount of norepinephrine and epinephrine and dopamine we have in our brain. That is determined by this COMT, which is catechol O-methyl transferase, which is an enzyme which is throughout the body, especially in brain, which determines amount of, say, catecholamines we have. And people have different levels of catecholamines. Because of that, different levels of catecholamine that changes pain perception. And Dr. Karash extensively talked about the ABCB1 transporter. That's a transporter which is an efflux transporter, the blood-brain barrier, that determines how much morphine or opioid we have in the brain. Mainly, we looked at morphine, and so it's an efflux transporter. Normal function of ABCB1 for morphine is to efflux out morphine from brain, out of brain to the systemic circulation. So brain treats opioids like toxins, or will try to get rid of opioids like toxins. So higher, in some patients, the ABCB1 may not function well. So because of underlying genetic variations. And in those patients, the ABCB1 transporter, if it doesn't function well, we have more levels of morphine and other opioids that can contribute to good pain relief, and also some central side effects, including respiratory depression and nausea, vomiting. And the endocannabinoid pathway, which works very synergistically with the opioid pathway, contributes to analgesia, also side effects, which is very relevant as we experience more medical use of marijuana. And opioid mu1 receptor, which is the main target for opioids. And so most of the opioids work via the mu1 receptor, and we looked at the genetic variations related to that. So that plays a major role in respiratory depression and also with pain relief. So before I go into the genetic details, so I'll start with a very simple thing. So what is a polymorphism? What is a gene? How we go about? So what is a genotype? So we'll take a morphine receptor, mu-opioid receptor as an example. So it's called OPRM1, and which is very well studied in adults, and not only for perioperative pain and cancer pain and other types of pain. So most well-studied polymorphism is called A118G. A patient can be AA type, AG type, or GG type. And the number of GG in, say, Caucasian population is about 2 to 3%. But if you go to China or Taiwan, the GG number may vary. So it's ethnicity dependent. That's why whenever we do the genetic study, we had to stratify by population. So whatever that's good for, say, a Caucasian population may not be good for African Americans. So this is mu1 opioid receptor gene, mu1 gene. You can see exons and introns. The one particular polymorphism we talked about is highlighted with the red arrow. It's A118G. So a patient can have AA or AG or GG, depending on what the genotype is. The amino acid will change. So if the amino acid change, this is the receptor protein. And so if the amino acid changes, then it will change the function of the protein. If the protein function changes, then it changes the effect of opioid we use. So in most of the GG type genotype patients, they need a lot more morphine for the same surgery, like 2 to 4 times higher dose. And they are quite resistant to opioid adverse effects, including nausea, vomiting, and respiratory depression. So that's briefly about genetics. So I'll go into the associations between multiple genes and the clinical outcomes we saw in our study. So we looked at obviously multiple genes, and when we started, we thought 1 or 2 genes will be important. Now we do the whole genome wide, and we look at all genes in our body, which is close to more than 20,000 genes. And that's why we started with 400 children. Now we need 2,000 children. So we are very close getting there. So we have recruited 1,500 already. So I will focus on the tonsillectomy population. And the main goal of our study was to identify children who are genetically predisposed to opioid-related adverse effects and also inadequate pain relief. The design was a prospective study, and it's a very observational study. And the clinical provider, the anesthesiologists, were blinded to the genotype because we took the blood sample, DNA sample on the day of surgery under anesthesia. So everybody did the standard of anesthesia, and we had a standard protocol. So we recruited children between 6 and 15 years of age undergoing tonsillectomy. And everybody had the same general anesthesia, inhalation, induction, sevoflurane, and everybody got Zofran, ondansetron, and dexamethasone for PONV prophylaxis. Children with sleep apnea got lower dose of morphine, and children without sleep apnea got higher dose. That's the only difference in the design. That's why we stratified by sleep apnea and accounted sleep apnea in all models whenever we look for any differences between the genotype. And as you know, tonsillectomy is an outpatient procedure, and Dr. Amram may not like the number of samples we took. We did only 4. And so the patients come on the day of surgery, and they go home within an hour after surgery. So we try to get as many samples as possible. And in our other study, which is spine study, we get up to 10 samples. So, we did 3 to 4 blood samples for not only for genotyping, also for morphine levels, morphine 3,6 glucuronide levels. And we did the hypercapnic ventilatory response before surgery and after surgery in children. And so we did that before exposure of to morphine and after exposure to morphine. So this is our setup. So you can see that it's a face mask, and the child would be here, and the face mask would sit tightly, and we have one-way valves. So here we have a Cosmo 2 monitor, which will measure breath by breath, end-tidal CO2, the tidal volume. We can get a minute ventilation with that. And also, I don't know that you can see it clearly, we have a pre-mixed 5% CO2 tank, which will be, opened to give 5% CO2 to stimulate breathing. And all data from this monitor is electronically transferred to our laptop. So the outcomes we looked at, pain outcomes and pain scores, how much morphine intraoperatively, postoperatively, and whether a child needed any intervention in the recovery room. Safety-wise, we looked at all side effects of opioid, including respiratory depression, sedation, nausea, vomiting, how long they stayed in the recovery room, and whether they needed any unanticipated admissions because of opioid adverse effects. So this is a snapshot of the genetic association with clinical outcomes. I'll be doing one by one briefly. And so COMT is associated with mainly analgesic outcomes. ABCB1 for the fatty acid amide hydrolase, which is in the endocannabinoid pathway, are associated with nausea, vomiting, and respiratory depression. And the transporters, the OCT1 and ABCC3, are associated with the morphine levels or morphine metabolite levels. CYP2D6, we talked about codeine-related adverse effects. And mu opioid receptor 1 is associated with respiratory depression in our spine population. So this is the comp data. You can see we looked at 4 different polymorphisms. So 1, 2, 3, 4. And we compared patients with the AA genotype with the EAG and GG together because these are called minor alleles. The frequency of them will be less. If you say, for example, here, we looked at the odds of receiving intravenous opioid in the recovery room after getting a standard dose in the OR. It's almost 3-fold higher in certain patients. So you can see that the AG and GG patients together compared to AA patients, they had a 3-fold higher need for postoperative interventions in the recovery room. And in the next one, so you can see also that's true for other polymorphisms as well. So compared to TT variation, the CT and CC patients require 3-fold higher. Then we put together all 4 polymorphisms together as a haplotype. When we combine multiple genetic variations called haplotype, then we saw some patients here, highlighted in green color, they needed less morphine compared to the haplotype highlighted in red color. They needed a lot more morphine. So that's one way of not overestimating the risk by doing the haplotype analysis. So briefly about the transporter, we had a full lecture on ABCB1 transporter, which is the blood-brain barrier transporter. This is the 3D structure with exact location of the genetic variants. So we can see those are highlighted where the docking station is, where the morphine and opioids would sit, how they are transported. So what we found is that certain patients, so this is one particular polymorphism, ABCB3 polymorphism. This RS number is typically used to identify a genetic polymorphism. You can see that the GG patient, which is quite rare in Caucasian population, but if a child has the GG genotype, that patient almost invariably will have respiratory depression, and that's what we found. And those patients stayed longer in the recovery room compared to the GA patient. GA patient is like neutral. And AA patients, on the other hand, very resistant to respiratory depression risk. And almost there's 8 to 10-fold difference between the respiratory depression risk between the GG patients and the AA patients. This is the CO2 response we did before and after surgery. So this is resting ventilation. So before surgery, we asked the child to breathe without giving CO2. Then we measured their minute ventilation. And this is one particular ABCB1 polymorphism called C3435T. And you can see that the at-risk patient at risk for respiratory depression is highlighted in red color, which is the TT genotype. And this is baseline before surgery. Before surgery, almost both groups, the TT genotype and the other genotype, had similar minute ventilation, almost 4 liters per minute. And after exposure to morphine, and we saw that almost 50% reduction in minute ventilation and the TT genotype, they behave differently. The TT genotype were more sensitive to morphine-related respiratory depression than the CC and CT genotype. And then we gave the 5% CO2 to stimulate respiration. And despite that, so we can see that before exposure, both groups were similar. And the minute ventilation increased from 4 liters to almost 7 liters. Then after surgery, and the drop in, say, minute ventilation, it was 50% in TT genotype, that improved to 30%. But the difference between the TT genotype and the rest of the genotypes still persisted with like 20% difference in the minute ventilation. This is all patients, a similar data. You can see the TT genotype in red color, and the other genotypes are highlighted in blue color. You can see that shift to right, after use of morphine, patients needed higher end-tidal CO2 to achieve same levels of minute ventilation. And also you can see that crossing of the lines here, and the TT patients had lower minute ventilation for same levels of entitled CO2 than the other genotypes. So that brings to our endocannabinoid system. So we all have endogenous marijuana called anandamide. So, and the amount of anandamide we have determines how much runner's high we have, how much happiness we get with meditation and other things with exercise. And so people differ in that. So that's determined by fatty acid amide hydrolase. The fatty acid amide hydrolase catabolizes anandamide. Anandamide is a very short-acting protein. So the amount of fatty acid amide hydrolase determines how much anandamide we have. Higher the anandamide, higher the good effects like happiness, bliss, and pain relief. And so that's what the medical marijuana does in the form of THC as an active component. And as we know that the active anandamide will function on CB1, which is cannabinoid 1 receptor and cannabinoid 2 receptor, and lead to pain relief, decreased nausea, and it can also sensitize, say, exogenous and endogenous morphine and opioids. So what we found is that, I'll go to this, one particular polymorphism of fatty acid amide hydrolase. This particular one is called C324420. It's associated with the respiratory depression and also respiratory post-operative nausea, vomiting in children. And this one, it's a missense mutation, meaning that it changes amino acid function, changes the function of fatty acid amide hydrolase, changes the level of anandamide one would have, and so that's what we see. It's also associated with addiction. So it's not only addiction to opioid, also addiction to the marijuana. Then we combined the ABCB1 and fatty acid amide hydrolase genetic interactions. Then we were able to better predict those at risk. So you can see that ABCB1 genotype TT and fatty acid amide hydrolase genotype AA patients had higher respiratory depression risk of like 46% compared to the opposite, the other extreme genotypes like CC of ABCB1, AA of fatty acid amide hydrolase. You can see the 46% versus almost 1.5% risk. Then we can even preoperatively do all these genotypes. We can assign a risk based on the genotype. We can see the GG patients of ABCB1 is almost 100% risk of having respiratory depression. Fortunately, that particular genotype is rare, and in at least in the US population. And majority of the US population are AA genotype, and that risk is about 7%. Even we can further divide them into subgroups based on the fatty acid amide hydrolase subgroups. In that we can, the risk of 7% can be further divided into 20% risk, 10% risk, almost 5% risk based on fatty acid amide hydrolase risk. So what it means for clinical outcomes besides, say, incidence of nausea, vomiting, besides incidence of respiratory depression. We looked at cost of staying longer in the recovery room. So for fatty acid amide hydrolase, one particular polymorphism, if a patient is AA genotype, they stayed almost a half hour longer following tonsillectomy. Tonsillectomy is a straightforward, simple procedure. If they stay half hour longer, that can lead to almost $160 in our setup. It can vary depending on setup compared to the GG genotype. The cost of doing this genotyping is very, very inexpensive. In our setup for this particular gene, it's less than $1. So the next gene we are going to talk about is mu1 receptor polymorphism, which is extensively studied. In our spine population, children, adolescents undergoing idiopathic scoliosis, they get morphine, and we see that AA genotype, similar to adults who had multiple studies in adults have shown the same finding, but no one had studied respiratory depression even in adults. So we show that almost higher respiratory depression risk in AA patients compared to the AG and GG genotype, less than 1% risk. So if we can identify those patients proactively before surgery, we can even lower the dose of, say, opioids, and we can give more of a non-opioid and opioid-sparing analgesics. This is the analgesic requirement and the pain scores. The AA patients are very sensitive to opioids. They needed less opioid. You can see that less morphine need compared to the other genotypes, and also they had better pain scores. Just to summarize, we had all these genetic associations: COMT with pain scores, ABCB1-FA with side effects, and OCT1, ABCC3 with the morphine and metabolite levels, and OPRM1 with respiratory depression. In addition, I'll briefly talk about non-genetic differences we observed, and we looked at Caucasian children and African American children. And what we saw was that Caucasian children needed less morphine for tonsillectomy than African American children. For here, the Caucasian children are highlighted in the red color and African American in blue color. You can see that 0.24 milligram per kg of morphine for Caucasian. Even though they needed less morphine than African Americans, they had a lot more side effects for the lower dose of morphine. And we wanted to study why. This is mainly based from self-report of race. Then we also correlated with the genetic race, with the genetic ancestry markers that had significant concordance. And we wanted to why there's a difference between, say, white and black children. And we found that the African American children metabolize morphine almost 25% faster. And then we asked why they metabolize faster. Then we found the OCT1 transporter. The main function of OCT1 transporter is to get morphine from the bloodstream into the liver cell. And so this particular transporter has genetic variation which is very high in Caucasian population. So in Caucasian population, there's more defective OCT1 transport, and that leads to higher levels of morphine in the bloodstream that contributes to more pain relief and also side effects. And the other one, once OCT1 takes morphine from blood to liver cell, then we know about morphine and uridine gluconyl transferase. Then morphine and metabolites, including morphine 6-gluconide, are transported back to bloodstream. That's by the ABCC3. And even though these two transporters are important, we think the ABCC3 is more important than OCT1. OCT1 changes the blood level, but it doesn't change clinical outcomes. But ABCC3 increases risk for respiratory depression by increasing morphine 6-gluconide concentration by 50%. I'll skip a couple of slides. And the sex differences. So we briefly talked about girls having more nausea, vomiting, more respiratory depression than boys. As the dose of morphine increased from 0.1 milligram per kg to 0.3, 0.4, we saw a higher incidence of respiratory depression, PONV, in girls, and also they stayed in the recovery room longer than boys. And almost 15 minutes longer than boys. Girls stayed longer in the recovery room for the same surgery. So to summarize, the non-genetic findings, so race, Caucasian children had higher incidence of adverse effects than African Americans. African Americans almost had no nausea, vomiting in our group, and they had higher need for opioids. Girls had higher PONV, respiratory depression, especially with increasing doses of morphine. And sleep apnea and the morphine dose, we all know from our clinical experience. And how do we translate everything into clinical practice? So what we have done is just put one genetic association into clinical practice, which is CYP2D6. And even though we have association for others, we had to validate before we bring that to clinical practice. So, and based on our research and CYPIC 2014 recommendation, what we do is in patients who come for major surgery, who would go home on oxycodone and other strong opioids, we do proactive, preoperative genotyping. We would know who is ultra-rapid metabolizer, who is poor metabolizer. Then we increase the dose or decrease the dose, or use hydromorphone for those who are ultra-rapid metabolizers instead of oxycodone. And where all these will go is, as we know, we had to identify a patient's risk not based on one gene, multiple genes. So we had to identify the genetic signature of a problem. It can be a respiratory depression problem, or PONV problem, or inadequate pain relief. Every problem will have its own genetic signature. So that's what we have done here for respiratory depression. we can identify those at 10% risk with almost 40% risk just based on genotype. We can do that even before surgery. And this way, we would know who's at risk for respiratory depression and other risk. And to an individual patient, based on multiple genes, we can say who is at high risk, who is at low risk. Our long-term plan, our future plan, is to just look at genetic factors and non-genetic factors proactively before even surgery, using a gene chip or something, point of care or preoperatively, and so that we can identify those at risk so that we can tailor therapy at some point. Yeah, the future looks promising. As I said, we have just scratched the surface. We have a lot more work to do and to validate and reliably. And one more thing is, so children have the same genes as adults. So we had to validate whatever we found in children in also adults. We have some funding for adult studies. If you guys are interested, we can talk more about possible collaboration. Thank you.
Senthil, thanks a lot for this interesting presentation. I'm thrilled, especially with the second part. Let me just ask the first question.
Sure.
How do you integrate the certain, factors? At first, you have to make a choice what to look at. You look at certain numbers, and I think even the ones which you say are non-genetic, most of them are genetic as well.
Yeah.
This becomes a very complicated model. This brings us back to the modeling.
Yep.
I think, how do you integrate this and move from looking at one at a time? Gender, for instance, was the easiest one.
Yeah.
Maybe all your girls had a special genotype.
Yeah.
And so forth.
Yeah, that's a great question. So we were very naive when we started the study 5-6 years ago. We thought, oh, we've got one gene, so OPRM one gene or ABCB one gene. So we will look at that in children and find something new. And that's why our initial sample size was only 400. And we initially started with, say, 15 genes and 50 polymorphisms. Now we do the whole genome because we don't even know which is important, which is not important. And as I mentioned, ABCC3, no one knew before our study that is a major transporter of morphine 6-glucuronide out of liver cell. So we are finding out a lot of even new biological transporters, enzymes in the pathway, the morphine pathway, opioid pathway, and pain pathway. So that's why we thought we will have unbiased view. So I would recommend doing a genome-wide study, like a GWAS study, with a very, very large sample size, so at least 4,000 patients. We are getting close to 2,000 range now. And also stratified by population. So as I mentioned, so African Americans are totally different from Caucasians, not only by race, even with underlying genetic inflammatory markers. So that's why we need to stratify by race with a significant power. When we started, we chose the genes and candidate genes based on biological pathway and pre-existing evidence. Now we know that there are a lot more to it. That's why we are doing the GWAS studies.
All right, thank you. Who was next? I think Carl.
Well, thank you for the review.
Yes.
All of the variabilities involved in opioid therapy. The thing I'd like to say, at the end of the day, there have been GWAS studies.
Yep.
We did a 2,000 patient GWAS study in the British Journal, I think it was, and they're looking for the effect of analgesia diagnosis in adults.
Yep.
Chronic pain.
Yep.
That's in a way not surprising. Many of us who pharmacology. Even if every one of the things that you pointed out there turned out to be absolutely true, the question is how many things have you not looked at?
That's
There are behavioral endpoints, all sorts of things. That's for analgesia. Then there are a different set of endpoints for respiratory depression. I'd just like to say I think one would be better if we pick an endpoint.
mm-hmm.
Pick one and see exactly what percent of the total variability you can account for.
Mm-hmm.
I have a feeling that you're going to find that there's a great deal that's still left unaccounted for, and we just don't know.
Yeah.
I'm not sure that all of it's been on this. I don't even know what the majority is.
Yeah. So that's a very great question. So why, say, 2,000 population adult study, GWAS study, did not show anything. And that leads to the robustness of phenotype. And so the phenotype has to be very robust to identify the noise. So I think if you have multiple surgeries, tonsillectomy to heart surgery to orthopedic surgery, and that contributes to noise itself. And if you don't do population stratification, that's another level of noise. And in that particular study, there is not much to improve the phenotype. And so the robustness of phenotype was very questionable in that GWAS study. That's why we limited to one particular population, tonsillectomy in children. And so they are not affected by multiple disease like CAD or asthma and other major chronic problems. And we chose acute surgical population because they are cleanest, probably, the pain population. Chronic pain patients, they have gene expression and other confounding factors. That's why we did not select that. That leads to how much genetics account for all these variations. So for, say, this is for addiction. So all these genes contribute to addiction. And there's almost 75% risk is from genetics. And only 25% is from environment. For respiratory depression, we think almost 50 to 60% is genetics. And PONV, similar, 50 to 60%. Physical dependence leading to addiction at some point. So these are all for dependence. So that's what we see. And the respiratory depression and dependence, they almost go hand in hand because most of the deaths in opioid dependence addiction is from respiratory depression. So and so we are looking at how the respiratory depression genes change the death outcome in opioid dependence now.
Short question, Mike. We already.
Okay, sorry. All right.
Mike.
Yeah, we can talk during lunchtime.
Mohammed.
Yeah. But this is about anandamide. Anandamide has been shown to have analgesic effects, and the THC, before finding anandamide, they found marijuana. So then they were looking for cannabinoid 1 receptor and cannabinoid 2 receptor. Our body has it, but there's no use for that. Then people abused or used marijuana, then found out about the CB1, CB2, then finally found anandamide. So anandamide has been shown to have analgesic effects. That's right. That's because of the fatty acid amide hydrolase.
All right.
Yeah, compared to morphine, anandamide is a very, very weak analgesic.
Thanks, Senthil, again for your talk.
So the next speaker,